recording of the meeting. So thanks, everyone. This is always, I feel like it never fails that with technology that's supposed to make things like this easier, often it ends up encountering many challenges, let's say, in getting started. So I think my lesson learned from this is to do a tech run through at least 24 hours beforehand, as opposed to just before the webinar begins. But we're always learning with our technology, so I just appreciate everyone's patience as we get started. For those of you who are joined us in the room, welcome. You are attending and participating in a quarterly for the Disaster Distress Helpline, National Suicide Prevention Lifeline, Ask the Expert webinar, Crisis Center as Safe Harbor, Trauma and Refugees. My name is Christian Burgess, and I am director of the Disaster Distress Helpline, which is a sub-network of the National Suicide Prevention Lifeline. I'll share my contact information at the end of the webinar as well, but if at any point during the webinar you have to jump off early and you miss anything, if you have any questions about the content that's presented today, or any questions or concerns at all, please take down my information and feel free to contact me after the webinar. But again, I will share this as well after the webinar is over. So a few logistics before we get started with the content. This webinar is being recorded, and with the exception of our two guest presenters, whom I'll introduce in a moment, please, for those of you in the room, the participants, please mute your phones, just so that we don't pick up any background noise. I can't tell you how many webinars I've been on, and I'm sure you've all been on webinars where you're listening to people place their orders for lunch and have conversations with coworkers, and so just as a reminder to mute your phones. For any questions or comments that you have throughout the webinar, and especially at the end when we'll make time for questions and comments, please use the chat feature, which is on the right of your screen. That's just the most seamless way during webinars like this to interact without any kind of audio interference. So please use the chat feature on the right side of your screen for questions, comments. And at any point in the webinar, I would love to hear see who is in the room. So please use the chat function to introduce yourself, your name and organization, and that way our presenters as well can get a feel for who's joining us today. So just at any point during the webinar, again, please introduce yourself via chat, your name and the organization with whom you're representing today. I do have a few supporting documents in the bottom right of your screen. I have a PDF of this webinar presentation and an overview of the Disaster Distress Helpline, so you can get more information about this program that's facilitating this webinar today. And you can download those files by highlighting the name of the file, and then you should get an option that says upload or download, or one of those anyway, and then you'll be able to save it to your computer and open it at a later time. So, and like I mentioned, we will have time for Q&A at the end of this webinar and discussion on the topic. But if at any point during the presentations a question does come to you or a comment, feel free to go ahead and type it into the box. That way, when it comes time for Q&A, I will facilitate. I'll go back and make sure that we see your question and get it to the presenters. So again, just utilize the chat feature during the webinar. The goal of this webinar is to enhance Crisis Contact Center's overall approach to trauma-informed care and serving individuals and families who may be refugees. And amidst all of the external and internal sources of distress and trauma and other behavioral health concerns, the crisis centers that you work with are safe harbors for everyone, whether through providing in-person services, through your hotlines, chat, or text services. Those of us who work in crisis contact centers, we're providing refuge through these services. Yet, of course, in our interactions with those who reach out to us for support, we don't always know what's beneath the surface. And so I think that when people do reach out, sometimes we may know that they are refugees, other times we don't. And so the goal, again, of this webinar is to enhance our overall approach to trauma-informed care. So not knowing exactly what the presenting issues are to the people who are reaching out to you, but so being a refugee could be one of those things that's underneath the surface, even if it isn't there uh, that you know of. So through this, through enhancing this overall approach to trauma-informed care, what we're going to be doing in this webinar is exploring, looking at key terms and definitions. We're going to receive an overview of current global crises that is fueling mass displacement. We're going to learn the risk factors for distress and other behavioral health concerns. And then, of course, we'll also be sharing resources, and not just from our presenters, but I'll have some additional resources at the end of the webinar for you to receive more information on the topic. And of course, we want to hear from you as well in the discussion as to what resources you may be aware of that can assist crisis contact centers and other invited guests in effectively serving refugee populations. Before I hand it over to introduce and hand it over to our presenters, I wanted to go over a couple of key terms, and this will be very brief. These are very succinct definitions. Of course, when we talk about both trauma and refugees, we could spend the entire hour just on definitions. But a concise definition or way of looking at trauma is that it's an emotional response to any event that involves experiencing actual or threat of harm, injury, or death to self or others. So it can be an event that you've experienced directly that involves harm, injury, or death, or that it's a threat of those things. And it could be you experiencing one of these things, or of course you could be a witness to someone else in terms of loss of life, harm, or injury. And when we think about trauma reactions, physical, emotional, psychological, we need to think about those in terms of immediate reactions, short term, so reactions that settle in, perhaps in the hours or days or weeks following a traumatic event. And then, of course, there can also be long-term traumatic reactions. So that's, again, a very concise definition of trauma. I know it's not comprehensive, but we'll hear more from our presenters on trauma in the context of refugees in particular. And in terms of a definition of refugee, according to the 1951 Refugee Convention of the United Nations, this convention spelled out that a refugee is someone who, quote unquote, owing to a well-founded fear of being persecuted for reasons of race, religion, nationality, membership of a particular social group, or political opinion, is outside the country of his or her nationality and is unable to, or owing to such fear, is unwilling to avail himself or herself of the protection of that country. So, kind of a complicated definition, but I think some of the keywords there I have up on the screen. It's a person who, because of persecution, is displaced from the country of his nationality, and they're unable to return, or it's unsafe to return. But again, we'll hear from our guest speakers more on what we think of when we think of refugees. So a few other background statistics to get us started here. And this points to the relevancy of this as a timely topic for crisis contact centers as well as other providers. The first being that since 1975, there have been over 3 million refugees admitted into the United States, and that's from all over the world. And in 2012, the most recent complete year for which I have data, there were 58,000 refugees resettled in the United States. And that the United States remains the largest resettlement country in the world, receiving more than half of all refugees worldwide each year through the United Nations High Commissioner for Refugees. So clearly it's a pretty large, when we think about various populations within the United States, clearly it's a very large population, and there may be communities that you serve that have a higher proportion of refugees than others, but refugees are in all 50 states and throughout the country. And in terms of trauma, we know from the Refugee Health Technical Assistance Center that different studies have shown rates of PTSD and major depression in settled refugees ranging from 10 to 40% rates of PTSD and 5 to 15% rates of major depression in settled refugees. So a pretty wide range based on a number of studies, but again, clinically significant when we look at refugees as a unique population. And within that, children and adolescents often have higher levels, with various investigations revealing rates of PTSD from 50 to 90% within children and adolescents, and major depression from 6 to 40%. So again, a wide range, but even at the lower numbers there, still represent a significant risk for mental health concerns within refugee populations. But so that's just some introductory information to get us started. I'm very pleased and honored, especially today, which many of you may know is International Women's Day, to have two very distinguished women experts in refugees and trauma. First, I'll introduce Dr. April Natural. Dr. Natural is a traumatic stress specialist who directed the mental health response to the 9/11 terrorist attacks in New York, and then spent several years in states providing management, consultation, and training in the aftermath of Hurricanes Katrina, Rita, Wilma, and Ike. April directed the BP Deepwater Horizon oil spill distress helpline, which was the sort of the precursor to the disaster distress helpline, also under the National Suicide Prevention Lifeline network of crisis centers. And Dr. Natural directed the 9/11 10th anniversary program in New York and Pentagon and Shanksville. Shanksville, Pennsylvania, and the Pentagon. Dr. Natural also helped launch SAMHSA's National Suicide Prevention Lifeline and an international not-for-profit Psychology Beyond Borders. She has developed training of trainers and capacity building activities in Uganda and Indonesia, was a curriculum developer for FEMA's Crisis Counseling Assistance and Training Program and the Boston Medical Center for Multicultural Mental Health's curriculum on responder resiliency. Dr. Natural provides disaster and terrorism preparedness and response consultation and training throughout the U.S. and internationally. She is currently the lead architect of the Boston Marathon bombing's behavioral health response and is training emergency response clinicians in Kiev, Ukraine. So very pleased to have Dr. April Natural joining us. And also we have Dr. Monica Indart, who is a licensed clinical psychologist providing an array of clinical and consulting services for crisis, disaster, and trauma-related issues. Dr. Indart helped establish and served as co-director of, and I'm going to just say the English version of this because I'll butcher the French, Doctors Without Borders, commonly known from its French name, but I won't butcher that. So Dr. Indart was the co-director of the Doctors Without Borders Psychosocial Care Unit, a specialized unit providing support and consultation to humanitarian aid workers. She has provided consultation, program development and evaluation, and professional training to the United Nations Secretariat, the UNDP, and UNICEF in areas of crisis and trauma response, peer support, staff care, and emergency preparedness. Dr. Indart worked for the New Jersey Disaster and Terrorism Branch from 2001 to 2010, and her work there included the 9/11 FEMA-funded crisis counseling program, where she specialized in organizing and providing services to immigrant and hard-to-reach communities. She has volunteered with Health Right International's Human Rights Clinic since 2002, providing psychological evaluations for asylum seekers, as well as program development, consultation, and training services. She has developed and delivered a training for mental health providers in the Ukraine on best practices and survivors of torture treatment services, and has provided consultation to a Syrian medical team developing mental health and psychosocial support services for refugees in Turkey. She maintains a private practice specializing in the treatment of severe trauma, grief, and loss, including survivors of torture, suicide, and homicide. And Dr. Indart has been an assistant professor at the Graduate School of Applied and Professional Psychology at Rutgers for the past 15 years and is a graduate of that program, earning her PsyD in clinical psychology in 1994. So, very distinguished guests, and again, just very pleased to have Drs. Natural and Indart with us. And with that, I will hand it over to them.
Great. Thank you, Christian. This is April. I'm going to start us off. I appreciate your kind introduction and for the opportunity to speak with crisis centers about this very important, pressing issue. It's certainly a privilege to work with you and the crisis centers who do such extraordinary work, as well as with Dr. Indart, one of our most esteemed specialists in the experiences of refugees and torture survivors. Um, can you forward the slides? I don't have control. Don't think. Great, thank you. I'm going to start us off with what we know about the most common events that create the need for people to leave their countries of origin. And I want to stress this. There was a strange event that happened during Hurricane Katrina. People across the country were calling those who left Louisiana refugees. Refugees are not people who move within their own country. They're people who move out of their country of origin, which is really an indication of the severity of the problems that go on that would cause people to leave. These are all traumatic events, these things that cause people to leave their entire country. The picture here was taken by a humanitarian aid worker who approached a child. The child was so used to being in an area where the family was being persecuted that she automatically put her hands up in surrender. A sad statement of some of the experience of our refugees, especially children. Full-scale war, or at least armed conflict, has been with us since humans began recording events. There has never been a time that we have been without them. A sad but true statement. And they're most often the reason that people leave their country, commonly after the conflict has either been going on for long periods of time, like we see in the Middle East, or if there's been an overwhelming sweeping of violence through a region where the inhabitants are totally devoid of any hope for things becoming safe enough for them to remain. Remember, most people don't want to leave their homes, or certainly not their country. Persecution, usually in the form of people being pressured to align themselves with a particular regime or support of ideologies regardless of their personal beliefs, is another reason. People are often pressured with persecution by threats to their own safety or the safety of their family members, very often learning of the disappearance of a loved one or being actually forcefully removed from their own homes. And Dr. Indart will talk a little bit about these events as they also generally involve torture about half the time. The other types of violence will often cause people to leave their homes, from armed conflict between warring factions within an area to community events that may involve rioting from citizens and killing protesters that erupts into continuous fighting and evokes a sense of fear that the country itself is no longer safe. We have certainly seen that over the years in areas of North Africa, the Middle East, these countries in the past uh, for many, many years, long periods where these countries have been in these kinds of community violence. Next slide, please. I wanted to show you this slide because it's important to review, since we're listening to so much political rhetoric these days about refugees and about how many people are out there. And certainly there is a larger number now throughout Europe. But this graph shows us that the numbers of refugees who've come to the US since 1975 have been in much larger numbers in the past. Some years, like 75, then 79 through 82, as well as other periods like 89 through 95, is when the US has taken in significantly more refugees than we have in the new millennium. I point this out so that we can all understand this is not a new phenomenon for the US. This is obvious when we look at our history in the early 1900s, when waves of European immigrants came here and eventually integrated into our culture. But it's our responsibility as behavioral health crisis centers to address the needs of these populations as best we can and ensure that we're providing information about the available resources and referrals for them and their families, in addition to addressing the acute crises that prompts them to call the hotline. But again, it's really important to understand these are not new phenomenon, and I'll be talking about who these refugees are, which is a very important point as well. Next slide, please. The current global crisis encompasses all of those reasons on the previous slide that people become refugees. There is the continuing exodus from several regions across the globe from long-standing conflicts, along with flight that's due to threats of death, and the imposition of religious and social ideologies that threaten individual and family safety. Additionally, mass migration is occurring in economically deprived areas, although it's very important to note that refugee status is not granted to those who leave their homeland in order to better their economic situation. They may become citizens of a country where they enter with an application, but it is generally not that they are given refugee status for that situation. And in this current global crisis, as I'm sure you've been seeing and hearing in the media, there have been statements and promises made to people. This idea that, the US streets are paved with gold, that have created false hope. Even Germany, which has taken hundreds of refugees, many are now being asked to be sent back to their homelands because they realize that those false statements just aren't coming true. There's no hope of bringing their families to live with them, no jobs waiting, no giant homes for them to live in, and no quickly prepared paperwork for citizenship. As a matter of fact, many of the refugees are being told that they will only be granted temporary status. Just this week alone, more than 8,000 immigrants were stuck on the Greece Macedonia border. Um, After Serbia closed its borders, then Macedonia followed suit. Um, the United Nations was very, very clear, saying that Europe was really on the cusp of a largely self-induced humanitarian crisis. There are about 130,000 migrants that have reached Europe via the Mediterranean so far this year. We hear that many of them are fleeing the conflict in Syria, but I want to go to the next slide and talk about who these refugees really are. I know this might be a little bit hard to read, so let me just bring you to the starting point on the right-hand side of the screen. The green spot where you see is Afghanistan. This is a visual here of how many countries are involved in the current refugee situation. The Afghan war, the Soviet war in Afghan between 79 and 89, it was a 10-year war that really left Afghan a shattered country, which was then taken over by the Taliban, and we all know what happened from there. Operation Enduring Freedom, 9/11. We also saw the horrors of Serbia, Bosnia-Herzegovina, Croatia, Kosovo, Albania, and Slovenia during the 90s. So that's right on the heels of the Afghan war. And the Afghan war continues. We can't forget that, despite the drawing down of troops. Thus, refugees continue to be on the move. So we see them going into neighboring Iran, then in Iraq, until there was a mass exodus from there into Syria and Turkey after 2001, when the US engaged in war in Iraq. By 2006, I have to tell you that the UN High Commission for Refugees begged for help with the Syrian refugee crisis and very clearly stated that the US had created it between the wars in Afghanistan and Iraq. Now there's an overwhelming number of refugees making their way into Greece, Italy, Germany, and other European destinations. And you can see they're going through Turkey, over to Greece, over to Rome. I'm sure you've seen this in the news, up into Germany and other countries where they thought they would be welcomed. But already, as I said before, hundreds are being returned, many by their own request because they couldn't have their family members with them or felt like they weren't being well cared for. They've complained about sleeping out in the cold. They're not being tents. They're not being food and not feeling welcome at all. And now knowing too that most of them will not be made permanent citizens. So while many will continue to be brought to the U.S., that means that the disaster distress helpline may become known to them. For many of them, it may be the only source of crisis intervention. These people, before they get refugee status, really become stateless. And they have these unique histories that will have an impact on whether your interventions can help them or not. Let's move to the next slide because I want to continue with the thought of who these people are. And as many of you know, the refugees Africa, from the East Coast, from Somalia, still the most dangerous country in the world, through Ethiopia and places where Dr. Indart has been working, Uganda, Burundi, South Sudan, the Central African Republic. Many of your communities have taken in large numbers of refugees from these areas. My point here in showing you the maps is that while you may be hearing on the news and preparing information based on what you hear about most of the refugees coming from Syria, the truth is that these refugees have moved from many different places, from Central and Northern Africa, from Afghanistan, Pakistan, Eastern Europe, over time, over the past 20 years. So you'll really have a great mix of ethnicities of the types of refugees who will be settling here in the US and will have access to the hotline. So you need to be aware of this so that you and your staff don't make assumptions about who these refugees are. This is not just about the current crisis, but it's about a very long history that's been continuous and created a number of refugees moving from one area of the globe to the other to try and find safety. Next slide, please. Images like this are not uncommon in many countries across the globe. And just as Christian mentioned earlier, we're becoming trauma informed in our approach to mental health treatment to clients. We must also be trauma informed when working with the refugee populations that we will encounter. For many of them, the PTSD that you saw in the slide that Christian introduced, along with depression, are the types of symptomatology that comes because of the traumatic events in the country of origin where the people have fled. Then for some others, you add on to that this process of leaving their families, of being isolated, of not being welcome, of having all kinds of stigma and barriers. And then we see depression on top of PTSD incidents. We need to be aware of what these histories are as we work with people and try and assist them. Next slide, please. So these are some of the risk factors that we see in refugees. Traumatic stress, again, often from the events that happened within their own country before they even got on the road, literally, to leave their country. For many, there are barriers to migration. Some cannot leave when they try to. Others get stopped at borders. Others are not welcome or have no place to go or no way to get there. Stigma and backlash is stronger than it's ever been due to terrorist attacks, especially in the West. We've seen some very, very unhuman type responses to the refugees, as well as some extraordinarily kind countries and individuals who've given up time to try and welcome refugees. But unfortunately, the larger numbers have been experiencing more stigma and backlash. Cultural barriers, I can't say enough about. We're not very good at really addressing cultural issues in the US or in other countries. There are so many large and small innuendos to different ways that cultures function that it is very difficult to become integrated. And we often don't even have the language skills that we need to have simple communications with refugees from different countries. Many of them just don't have the access to get anywhere else. And as we said before, and there are over and over and over again, empirical evidence telling us that separation and isolation from social supports is highly, highly damaging. And many, many refugees don't realize this until they get out of their country. They're on their own and they are totally isolated, not only from their families, but from other refugees who may have had the same experience or have been coming from the same situation as they. And unfortunately, we see desperate parents sending their children out alone. And this creates the current human trafficking problems that we have been seeing increasing across the globe as well. It's very frightening. Next slide, please. So I'm just putting here a short list of interventions, and Dr. Indart's going to speak in some detail about some of the needs specifically. But these are some of the things that we know can help people who are refugees And while crisis centers may be able to assist in providing some of this information, much of it is needing to be provided over a long period of time and often by many hands, many different agencies and organizations, which makes for a long process and a difficult one for refugees who are eager to be settled. While these interventions are not in a priority order, the first one is, in fact, the priority. Safety is the basic human need that everyone requires in order to be able to function, to relate to others, really to do anything in a state of reasonable, sound, clear thinking. And so safety is our number one priority. And that's something that crisis centers, I think, are particularly good at. Being that social support, being able to do crisis intervention, being able to provide a sense of safety that, yes, you're here, there's someone to talk to, there's someone to help you link to the resources that you need, is an extraordinary gift that crisis centers can provide for refugees. And as you see, it is the number one issue on the list that we need to address with refugees. Then we have, of course, all the other needs, access to health and behavioral health care, trying to help them connect with families or other social supports, people who may have come from the same geographic reason or had the same kind of experience. Obviously, language supports, we need to be able to communicate, economic supports, and then finally, in some way, shape, or form, however, we might be able to help them with integrating into some community. And we hear all kinds of stories of how communities take in refugees and learn simple ways of helping them to feel integrated and to moving towards acceptance. What you see after that, there are many other interventions that we can help, are things that the refugees will tell you that they need. Things that make up the work are things that the refugees tell us are more important to them. And that's where your assistance in providing the right types of resources and referrals can help out. So again, this is a short but important list, and it was an overview of what we're talking about. I'm going to turn the webinar over to Dr. Indart, who's going to continue with the next slide and talk more specifically about these issues.
Thank you, April. And I just want to thank Christian and the Disaster Distress Helpline for providing what I think is an invaluable service and an opportunity for us to connect even briefly. And I just have to say what an honor it is to present with Dr. Natural. I learn from her in every contact I have, and she is one of the world's true gems. So that's an honor, and I thank you. Christian, I think I can use the slides, forward the slides on my own, but if that's not happening, then I'll ask you to take over. So we're going to leave this short video clip toward the end if we have time. We've had a bit of technology issues this afternoon, and I don't want to delay us further. It's a under 3-minute video that is a quick summary of a woman who is herself an immigrant and is a commander of a rescue ship that MSF, Doctors Without Borders, uses to rescue refugees at sea, and a short brief note about their mission, and it's quite moving. The name of the ship, it's been renamed Dignity, and I just sort of want to start off by the definition of dignity that the commander of the ship states, which is the state or quality of being worthy of honor. The state or quality of being worthy of honor. And I think if I had to summarize, encapsulate what I feel is most important in working with refugees and this population, it's to be able to support their dignity and honor their suffering and their strength. And as Dr. Natural noted, I can't think of a better resource or a better group of people than the staff of all of you in the crisis centers providing this kind of work, because I think you know how to do this and you understand its value. So a big thank you to all of you as well. Something we're all familiar with, Maslow's hierarchy of needs, is particularly relevant to working with refugees and families who've been displaced. And so to understand that until biological and physical needs are met, it's very difficult to talk about other issues, and to recognize that although once coming to this country, many of these biological and physical needs have been met, these individuals and families have long histories, not just a few months, but long histories of severe deprivation. And so the notion that one can go without food, water, shelter becomes commonplace. And people adapt to things that are just astonishing because of the strength of the human spirit. Dr. Naturel noted the importance of safety. And again, this is what I think all of you in the crisis centers excel, is in providing that sense of safety. Not just the physical sense of safety, but the psychological sense of safety. And that's a huge service to be able to provide people, to give them an opportunity to see if they can feel safe again, having lost that sense. And then belonging and love. And it may seem odd in the face of such tremendous deprivation and trauma, but to never forget how these needs for belonging and the needs for human connection are what allow people to survive these kind of extreme experiences. I'm just going to pick up on two of the risk factors that Dr. Naturel so thoughtfully and expertly summarized. And one is, a point that perhaps doesn't need to be made again, but is such a key issue in terms of all areas of functioning, and that's the effects of traumatic stress. And in these cases, we all are aware of this, but for a moment, to let the awareness sink from our intellectual understanding of this, to let it sink into our bodies and our hearts about what it might mean to live under these conditions. The intense and prolonged exposure to extreme events, extreme weather, extreme deprivation, extreme desperation, separation from family members, the intensity of the traumatic stress and how prolonged it is. People may come to Lesbos in Greece and feel that they have reached some modicum of safety, only to learn that they're just going to be in a processing camp for maybe 3 weeks at the most, more like 5 days, and then they're going to be shipped off again. And that's that kind of extreme uprooting and extreme instability. Again, the prolonged deprivation of basic human needs. We're talking food, water, shelter, the things we take so much for granted, that these are long-term deprivations. And then the intentional infliction of violence. And again, a level of violence that is extreme. In particular, in terms of Syria, to be living in a country where your government is using cluster and barrel bombs, where they're using nerve gas agents, sarin nerve gas, chlorine, all manner of extremely violent, destructive sources of trying to control the population. And that's really what people have been struggling with in countries like Syria and Iraq, is the struggling against a regime that has been trying to control their souls and erode their souls. So the most extreme of this is torture, and I'll come back and talk about that briefly. Very quickly, in terms of, let me just go to the next slide here. Separation and isolation is another point that Dr. Naturel brought up that I want to highlight. And here we're talking about the impact of destruction of social and cultural bonds, which limit the natural sources of resilience over time when one is separated from one's family, from one's culture, from one's institutions, how that erodes resilience and strength, which puts one at increased risk of depression. And then the long-term effects on physical health of this kind of deprivation and this kind of erosion in terms of immune system functioning. And although it doesn't get the same kind of attention as torture and some of the more extreme experiences, to note how the destruction of cultural iconography has such a terrible effect on individuals. It erodes historical memory. And here real quickly, I just want to weave in a quick case example, and just using a pseudonym to protect confidentiality. Ahmed was a economist, is an economist. I still have contact with him, that I was working with in southern Turkey, in Gaziantep, very close to the Syrian border. He was working with a an NGO, and the entire team was a team of refugees in exile from Syria. Primarily medical personnel, physicians, nurses, pharmacists, and Ahmed was the only economist there. He had a particularly eloquent way of expressing himself, and he cannot go back. Like everyone, he would risk his life in going back. His entire family, with the exception of his mother, were tortured and murdered. So it's just him and his mother is trapped in Damascus. She can't leave. He speaks with eloquence about, and said to me, I have memories. I remember what like before the regime. I remember going to museums and palaces. I remember studying art and literature. I have these memories, and now I feel that that is all I have are these memories. So the sense of tremendous isolation and deprivation he felt, being separated from family and culture. In working with individuals, refugees were always working within these three spheres and across these three spheres, understanding how they interact and intersect and influence one another. The effects of traumatic experience on the brain, mind, and body, and brain and mind are not the same things. So to understand that there's influences on the brain, there's influences on the mind and on the body, and how culture influences all these different aspects. So just to have this sort of graphic in mind when we're working particularly with refugees, because it can be helpful to keep these concepts in mind. I'm going to talk a few minutes now about torture, because we're learning that there is a high percentage of refugees in the current crisis that are survivors of torture, and it's an area that I've had some experience with over the last 15 years. This is the United Nations Convention Against Torture definition, Article 1, which defines torture, and you'll have these slides and can read it. But essentially it is the infliction of severe pain or suffering, physical or psychological, which is intentionally inflicted on a person for specific reasons, to get information from that person, to keep that person from testifying, for a variety of specific reasons. But the point is this kind of infliction of severe pain, severe damage, and trauma is done by state actors acting in some official capacity. So it is done by governments, by representative of governments to individuals and to families, and has particularly damaging effects on individuals. This is, without distressing people unnecessarily, this is a drawing by an Eritrean torture survivor who did not have the words to express all that he had witnessed and all that he had endured. So he drew a series of pictures depicting what he experienced in Eritrea before he was able to flee. And again, just to note the power of these images. And also to keep in mind the strength of the human spirit that can endure. There was a 2015 meta-analysis done by the Center for Victims of Torture in Minneapolis, one of the largest centers in the country. For a long time, we've assumed that the number of torture survivors in this country was around 400,000 or 500,000. And now we see that that's a gross underestimate, that it's probably closer to 1.3, 1.5 million, and that the prevalence of torture among refugees is as high as 44%. And I will tell you from my experiences, I suspect that that's a low estimate now. So almost half, perhaps more, of refugees have experienced torture at some point in their experience. Now, it should also be noted that this figure does not include people, refugees who are seeking or have been granted asylum, people specifically seeking a legal status based on torture. These are people who are not disclosing torture. So just something to be aware of as crisis center workers, that this is something, the experience of torture is often experienced by refugees, and they do not talk about it for shame, for fear, for lots of reasons. It's estimated that for those who have experienced torture, rates of depression are about 4 times higher than in refugees who haven't experienced torture, and rates of depression are rates of PTSD are 4 times higher, and rates of major depression are about 2.5 times higher. Torture is a different experience than trauma. It is the most extreme kind of experience, extremely personal and interpersonal, and involves the infliction of torment according to assigned roles. So it's something done to someone in a more helpless position by someone in a more dominant and controlling position. It represents the most extreme forms of human suffering, and for many it involves a confrontation with evil. This is an older study, but Basalu is a psychologist in Istanbul, Turkey, has established a large torture treatment center there, and although in 1994, this study still holds true. There are 3 types of stressors that he found in Turkish torture survivors, and we find this again still to be true today, and I just want to highlight these. The severity of the torture is related to PTSD symptoms, not necessarily so much to depression or anxiety, but more to PTSD. Makes sense. Lack of social support is predictive of depression and anxiety, but not necessarily PTSD, a bit different than some of the US research. But then what I want to highlight is that the impact of captivity on the family is the strongest predictor of PTSD. So many people who've been refugees, part of their torture has been being held in captivity, whether that's as part of a state-sponsored act of terrorism. Being in a refugee camp is actually, considered a experience of captivity. The same with an internally displaced persons camp, and that these have strong, strong effects on families as well as the individual. And as April's image a little earlier highlighted, the power of images to be thinking of what each of these individuals are experiencing, that child being passed through a barbed wire fence, the families or those who are trying to help pass those children. You see the man holding a baby at the same time, and to be just imagining those experiences embedded in one's memory. A few brief words about intervention, and please, I will ask April to join in here. Steve Hobfall and his colleagues in 2007 published an article that looked at the 5 essential elements of interventions for mass traumatic events. And this is well known now and well documented. As Dr. Naturel mentioned, safety being the most dominant one. The capacity to provide a calming presence. Self-efficacy, the ability to foster the sense of competence and strength in people. Human connection, just as human connection can tear apart a human being, it can also heal and connect human beings to the human parts of themselves again and to one another. And hope. I feel that as clinicians, we don't leverage hope enough, and that an important part of what we can do is hold the hope for those who have temporarily lost it until they can find it in themselves once again. This model comes from the Harvard Program for Refugee Trauma and Global Mental Health. Richard Molnica has dedicated his life to working with refugees and torture survivors, and it's called the H5 model. And quickly just reviewing these each different segment, I find this model particularly helpful in working with refugees, if I can say. One is to always maintain a human rights orientation. The second is to understand and allow for experiences of humiliation and to be able to respond to those with empathy and care and compassion. The idea and the notion that within each of us there is a strong capacity for healing, that we can heal ourselves as well as one another. To promote health, as Dr. Naturel had mentioned, the strong effects of the refugee experience, the negative effects on health, to be able to take a health promotion approach. To understand basic needs like housing, but housing is more than just housing. It's also the French notion of habitat, which is one's environment. And then within the core of this is the refugee's trauma story. So just to summarize, and then we'll, I would like for Dr. Naturel to comment. I just want to say one quick thing that I didn't put on this slide. One of the most helpful things we can do is use someone's name. It is for the refugee who has become faceless, it allows them to be seen and to be heard, and that's a healing intervention in of itself. So use someone's name. There was a refugee in Greece that a colleague of mine was telling me about, and he had come through and then came back through some months later, and she remembered his name, and he was astounded that she remembered his name. And I also wanted to note how Dr. Natural said hello to everyone by name when we started, and I thought that was particularly an example of this. Use the H5 model as a structural foundation with the 5 essential elements as a basic strategic approach, and then tailor it. So tailor that to the situation. Provide a human rights, social justice perspective in all you do. And above, always remember, take care of ourselves. Take care of yourself. There's only one you, and we need you to be whole and healthy for what you do and to attend to self-care. So, Dr. Natural, you want to comment, please?
Only thing I wanted to add, I love the points that you made about using refugees' name. Identity becomes one of those things that we didn't talk about a lot, that when people lose their home, lose their country, this sense of self starts to fade. And simple things that crisis counselors generally do in the crisis centers are things that can really be helpful. And we don't want to minimize any of those basics that those of you who are on the lines with refugees and other callers, the things that you do that seem simple and basic to you can really have a strong effect on the refugees. The other thing is, going back to the tips for crisis counselors, I wanted to point out that needing to tailor our approach. Don't forget, as most of you do on the crisis lines, is to ask the refugees what might be helpful to them. And that's what tailoring really means. Again, just as we can't assume what their particular experience was, we need to ask them what their particular needs are. Some may not have a need for language issues. They may have, they may speak 5 or 6 languages, understand English well. That might not be an issue. Others may have more of a concern for a family member than for themselves. And so tailoring has a lot to do with talking to the refugee and finding out what it is that they need. And you are a social support. This connection to the crisis hotline is going to be very, very important to them. And so I think each of these things can really help as we move along and learn what it is that the particular refugees may need. I think we have time for your video,
Thank you.
Monica.
Christian,
Sure.
are we able to
Yep.
do this? Would folks like to see this? About 2.5 minutes.
Yep, I can work on queuing that up. While I'm queuing up the video, Anna Duffy just posted a question about getting a copy of the information. And so, Anna, I'll post this in the chat, but the pod below the chat function, if you highlight the file that says DDH Trauma and Refugee Webinar, that's a PDF of these slides. And as well, this webinar is being recorded and then will be created. A web link will be created to share with the Lifeline network, as well as just upon request from any other participant in the room, and we'll share our contact information at the end. So let me cue this video up. I just have to switch modes here real quick, so just bear with me. And
we'll also, April and I can respond to questions in between.
Okay.
Thank
and
you.
Monica, can you see the video here?
Yes.
Okay. And hopefully the audio come through. So let's try it and see if the audio comes through. Pressing play.
I don't know if we have audio on this.
Okay. Sorry about that, everyone. I tried to use the live screen sharing options in hopes that the video, but I guess that's not working. So I'm just gonna no problem. I'm just gonna switch back to the basic presentation. But to echo Monica, I do encourage everyone to look at this video on your own time at the after the webinar. So April and Monica, any did you want, before I move into other questions and comments, any other parts of the presentation?
Just the last part, we didn't get a chance to talk about the resources that are up on the last slide. So do download the PDF so that you can access these resources. The refugee issue is a global issue, and so while there are large refugee programs here in the U.S., there are also larger programs that are run through the UN and a number of agencies that act worldwide as well as here within the U.S. So we hope that these are useful for you. And I just want to add that in our work across the country, both Dr. Indart and I come across small pockets of immigrant and refugee communities in places that are, you know, places we don't expect, in very small towns, in small areas, as well as in large cities. We see pockets of immigrants, whether it's those from Southeast Asia or from the Mid East. There's a large Vietnamese population in Alabama in a small town. Who would think of things like that? So I know that you do this already, but as crisis centers, we urge you to learn what refugee and immigrant communities may be in your nearby areas so that you can add them to your list of resources and referrals, because people do tend to stay close to those that they know, and you might not know unless you go looking for these particular communities in your areas.
April, or Dr. Natural or Dr. Indart, I have a question about that. Is that it can be challenging for crisis centers and other providers who have services available to refugees to reach such individuals and families, even if they are in their own backyard, to let them know that support is available and in their community. Do either of you have any suggestions for crisis centers or other providers in terms of outreach and engagement?
I think that we use the same rule that you do already now, although Dr. Indart might have some more suggestions. And I do suggest that you go through some of these resources, because a lot of the folks at these centers already have relationships with these groups. So they might help you, or you might yourself be able to find a particular liaison, somebody from within the group that's willing to talk to you. I think cold calls or cold visits don't work. You're very likely to be turned away or get a cold shoulder. So do reach out to the resources or a particular person who you know might be able to act as the liaison for you to bring you into the community. Dr. Indart, I don't know if you want to add to that.
I agree completely, and to use the sort of natural points of contact, houses of worship, primary care clinics, schools, to use those natural points of contact, and
right.
the message is integration and support.
And I think, and I'll just add on to that too. I think that it's important for crisis centers who are located in communities where there are known significant populations of refugees. I mean, again, there could be just individuals or families, and then other communities may have neighborhoods with high numbers of refugees. And I would encourage crisis centers, I posted earlier in the chat, to look at what materials you have in the language that might be spoken by within these communities, the primary language, as well as to make sure that your staff are trained and equipped to use the third-party interpretation services that all of our crisis centers have access to. I think that understandably, many individuals that we serve in the communities, they just simply aren't aware that they can even reach out to our basic services because they assume that they're only in English. And that's in addition to the cultural barriers and the other barriers that anybody has when it comes to reaching out for support. And so those are just a couple of resources I encourage crisis centers to make sure that you're using, both translated materials and training in how to use our third-party interpretation services. We're running out of time here, but I did want to put up some additional resources. Just there you see the website for the Disaster Distress Helpline. We are the nation's only 24/7 crisis hotline dedicated to providing emotional support to survivors and responders of natural and human-caused disasters, including those in the U.S. who may have refugee status as a result of war, conflict, or other forms of persecution. So I encourage you to familiarize yourself with the Disaster Distress Helpline as a 24/7 support national resource. The DDH and Lifeline are programs of the U.S. Substance Abuse Mental Health Services Administration, and you see that SAMHSA has a resource page dedicated to trauma and violence, and that link is there. And then some of these other websites, again, they're in the PDF of the slides to download. They just have more information about trauma and refugees. I also want to put up our contact information, myself as the facilitator of the webinar, as well as Drs. Natural and Indart. You see their email and phone numbers here. If you have any questions or would like to follow up on any points raised or resources provided, please feel free to reach out to us. And I just want to thank, again, Dr. Natural and Dr. Indart for taking the time, for bearing with us at the beginning of the presentation with the audio difficulties, but for the mostly and certainly for all of the extremely valuable information that you've provided today on trauma and refugees. This webinar, again, will be recorded and used as a legacy resource for crisis centers around the country. And for those of you on the call from crisis centers, I will be sending out a web link to the webinar in a future. We're just jumping off if you're using this line right after us. We're just wrapping up a webinar. Anyway, so thanks again to everyone for participating. I will leave up this I'll go back to the screen with contact information in case you need a couple more moments to write that down. So we're signing off now. Thank you, Dr. Natural and Dr. Indart.
Thank you, Christian.
Thank you. Thank you so much, everyone.
For all of your work. Take care.